Welcome. In this second session on gross brain anatomy, we'll address the blood supply to the brain and to the brainstem and identify the meninges, ventricular system, and the cerebrospinal fluid, as well as the blood-brain barrier. When we talk about the blood supply, we're interested in the dual arterial supply to the brain first, the territory supplied for the cerebrum, the brainstem, and the cerebellum, and each of the vessels that supply those. The control of cerebral blood flow, and then the meninges of the brain and the clinical implications of the spaces between those meninges. We'll look at different kinds of hemorrhages that are associated with the cerebral vessels, as well as the ventricular system, choroid plexus, which generated the cerebrospinal fluid, and the flow of CSF, cerebrospinal fluid, through the ventricular system, and the role of CSF. And then we'll look at different aspects of hydrocephalus, including communicating, non-communicating, and normal pressure hydrocephalus, and others. The dual blood supply includes two major systems: the anterior circulation from the internal carotid artery and the posterior circulation from the vertebrobasilar system. We'll see that they join together at the base of the brain to form the circle of Wilson. We'll start out with the anterior circulation, which you see here. The anterior circulation comes off of the internal carotid artery that we see here. And coming off of that internal carotid artery are the middle cerebral artery that you see right here, the posterior cerebral communicating, that's the posterior communicating artery, as well as the anterior cerebral artery that you see coming to the midline, and the anterior communicating artery that connects the two anterior cerebral arteries. If we look at the posterior circulation, it starts back here with the two vertebral arteries coming together to form the basilar artery, this big fat basilar artery. Coming off of the vertebral arteries, we can see a couple of arteries. Some are the posterior spinal artery, and also the anterior spinal artery, which will come down to form the spinal cord. But we also see supporting the brainstem, the pica, the posterior inferior cerebellar artery, which supplies both the medulla as well as the cerebellum. And then as we come up to the basilar artery, which supplies a good portion of the pons, we see coming off the basilar artery the AICA, the anterior inferior cerebellar artery, which feeds the brainstem at the pontine level as well as the cerebellum. And then above we see the superior cerebellar artery coming off of the basilar, supplying the upper portion of the brainstem, that is in the midbrain, as well as the cerebellum. And then we see the posterior cerebral artery. And recognize when we get up to the posterior cerebral artery, we're feeding into also, not only that feeds the occipital lobe and portions of the inferior temporal lobe, but also it has a branch that is attached to the posterior communicating artery, and that will connect us to the circle of Wilson. We can see that a little bit more closely here. But we notice when we see the brainstem in true dissection, we see the basilar artery here, and all of the arteries that we have named are located here. And you see the vertebrals coming together to form the basilar. And note that right near superior cerebellar artery and the posterior cerebral artery, we see the oculomotor nerve, that's cranial nerve 3, which will become important if there are swellings or hemorrhages around the top of the basilar artery or near the posterior cerebral artery. So we see the posterior cerebral and posterior circulation and the anterior carotid artery. And coming together right here at number 4, the posterior communicating artery, which connects the anterior circulation to the posterior circulation. An interesting clinical correlation is that on the medial surface of the temporal lobe, we see the uncus, this little bump, and that if there is an aneurysm in this region, in the posterior cerebral artery, which we see coming off here, or the superior cerebellar artery, coming over here, then when they swell up, they might press on cranial nerve 3 and it causes a cranial nerve 3 palsy with oculomotor problems. And notice that the uncus is close by, and that may also, if it swells up, press on this cranial nerve 3 and produce third nerve palsy. If you inject a contrast material into the internal carotid artery, you can see the various portions of the internal carotid artery, the cervical, petrous, cavernous portion, and then the cerebral portion. And various branches off its 2 major derivatives, and that is the middle cerebral artery, and you see various levels of those breaking off of that internal carotid, or the anterior cerebral artery. If we look at the midline, we can see the distribution of the anterior cerebral artery. It comes off of the internal carotid and feeds the front mesial portion of the frontal lobe, and then extends all the way back over the corpus callosum to feed the medial surface of frontal lobe and parietal lobe, even extending back to the far parietal lobe. We see the posterior cerebral artery feeding the inferior temporal lobe as well as the occipital lobe. We can see here the anterior communicating artery that connects the 2 anterior cerebral arteries, and we see the internal carotid artery as well. Coming off of that region, we can see a smaller artery, the medial striate arteries, and they supply some of the deep structures of the brain. The posterior communicating artery that we see here connects this posterior cerebral, right up here, up towards the internal carotid artery, and will complete the circle of Willis. We can also see a small branch, the ophthalmic artery, coming off of this internal carotid artery, and that will feed into the eye. The middle cerebral artery, the most extensive of the cerebral arteries after coming off of the internal carotid, feeds the entire lateral portion of the hemisphere. There's one on each side, and it feeds the deep structures as well. You see the insula in here. Coming off of the middle cerebral artery, you see a number of branches that feed deep structures, the lenticulostriate branches of the middle cerebral artery. They feed important structures here that we'll refer to a great deal later on, including the basal ganglia, the putamen and globus pallidum, as well as the internal capsule, genu and posterior limb of the internal capsule in this region. The vertebral basilar artery, that is the posterior circulation, includes, as we described, the basilar artery, the vertebral arteries, the posterior spinal artery coming off of this vertebral, as well as posterior inferior cerebellar, anterior inferior cerebellar, posterior cerebellar, the superior cerebellar artery, and the posterior cerebral artery. Pica, most will be given a great deal of attention because a blockage of the pica, which feeds the medulla as well as the cerebellum, produces the Wallenberg syndrome, and that has several different symptoms that and signs that we'll be discussing later on. The posterior cerebral artery, seen here, supplies the ventral and medial surface of the temporal lobe and the occipital or visual cortex, right up to the parietal occipital sulcus. It also has branches to the midbrain and to the thalamus. The anterior communicating artery we can see right here, the anterior cerebral arteries, and the entire circle of Willis is represented here. If a particular portion of that circle of Willis is blocked, as we see right over here on the posterior cerebral artery, if the circle of Willis is intact and conducting, allows blood to flow, then this portion over here that might otherwise have been blocked, coming off the basilar, coming into the posterior cerebral, may get blood supply from the other side and feed that posterior cerebral. And the same occurs for each of these different regions, that if there's a blockage at one location, the other side may feed that through the circle of Willis, depending on how patent the circle of Willis vessels are, which varies from patient to patient. This is a quick summary of that cerebral circulation. Here in green, we see the entire middle cerebral territory. If you put your hand over your side of your head, over your ear, that's about how much the middle cerebral covers. And then at the posterior edge, you'll see the posterior cerebral artery, and more anteriorly, you'll see the anterior cerebral artery. If you look at the midline, you can see that a great deal of the midline of the cortex is fed by the anterior cerebral artery, and more posteriorly, the posterior cerebral artery. If we look inferiorly, we can see that a great deal of the inferior portion, the occipital lobe, temporal lobe, is fed by the posterior cerebral artery, and then more anteriorly, a middle cerebral and anterior cerebral artery. Important concept is the watershed zones. So if this is the middle cerebral artery distribution and up above is the anterior cerebral artery distribution, the territory just between those would be referred to as a border zone or the watershed areas, the same as between the middle cerebral artery and the posterior cerebral artery. It's a watershed zone. What that means is that if there is reduced perfusion from the heart, those areas that are most distant from these two adjacent zones would get the least blood supply, and they would be cut off, and they would produce particular syndromes that we'll talk about. Particularly if you lose circulation to this region, you would see what we call a man in a barrel syndrome, and we'll talk about that, where the man might be unable to move various parts of the body. The locations that we identified that overlap between the middle cerebral artery and the anterior cerebral artery are right here, and that's at the level where different parts of the body are represented. Particularly the trunk is represented right here in this watershed zone, and as a result, particularly the shoulders and the hips, and as a result, decrease in blood supply to this overall anterior circulation. It would decrease blood pressure and inadequate circulation. This, as think about water sprinklers that feed this very well, don't reach here. They would produce a loss of function here that we call man in a barrel, where the muscles of the trunk, that is the shoulders and the hips, would be weak, and a person would still be able to move their fingers and their toes, but not their hips and their shoulders. Control of blood flow is under an autoregulation system that is relatively well controlled, so that if neurons are very active, then in fact more blood flow will come to those very neurons, as reflecting the change in activity. And that's influenced both by astrocyte function as well as neural activity, and glutamate that influences the activity of astrocytes, because when there are a lot of neuronal activity, you tend to have a lot of glutamate activity, and the glutamate activity will influence the astrocyte function and flow of blood in these vessels within the brain. Covering the brain are a series of layers of protective tissue, connective tissue. You see the dura mater is the outermost. You next see the arachnoid mater, the middle layer, and most innermost, the pia mater. We're looking here at the dura, and the dura has been peeled away. It's very tough connective tissue. Just under it is the arachnoid that we see spanning over the sulci, and then going down into each of the sulci, and most adjacent to the brain cortex is the pia mater. We see here in a cross-section, a coronal cross-section, various aspects of the pia mater adherent immediately to the cortex, and then just above it, the arachnoid mater, and recognize that there's a great deal of cerebrospinal fluid in this region right under the arachnoid, and then a very tough dura, which near the midline splits into two separate sheets, and that forms the superior sagittal sinus at the midline. This dural separation goes all the way down to the midline and deep between the hemispheres, and it forms something known as the falx. It's a very tough membrane and separates these two hemispheres absolutely until you get down to deeper structures where the corpus callosum is. Notice that within this arachnoid mater, you have this meshwork function, and it's within this region that a great number of the cerebral vessels and veins are located. And then they will dive down into brain tissue at various locations. You see these separations a little further as you go down into the spinal cord and recognize that it is continuous all the way down into the spinal cord, that dura. We see some of the dural separations. We indicated earlier that going down towards the midline is the falx, also known as the falx cerebri. Something comparable is going down into the region of the cerebellum, and it will separate the two sides of the cerebellum, but also separating the cerebellum from the occipital lobe. We see here the tentorium cerebelli, also a very tough tissue that separates brain tissue in the cerebrum from the cerebellum at this location and travels up all the way towards the area that separates. In this setting, the temporal lobe is down in this region right here. So we see the falx cerebri here, the tentorium cerebelli here on both sides, as well as the falx cerebelli. We talked about the venous sinuses, that is, the various veins will drain from the arachnoid into the cerebral sinuses to the dural sinuses. This is the superior sagittal sinus. This is the subarachnoid space. But blood veins in this subarachnoid space will drain into the sagittal sinus. We'll see sinuses in a number of different locations, and you see some of those indicated here. And we'll see those on images in many other settings. So you see a sigmoid sinus, which is a curved sinus back here, a confluence of sinuses right here where the superior sagittal sinus meets the transverse sinus and meets also the straight sinus. And then you'll see the ophthalmic vein over here and a superior petrosal sinus indicated right down here. And then there's a very large cavernous sinus through which a number of cranial nerves you'll see will travel, including cranial nerve 3, cranial nerve 4, as well as cranial nerve 6. And a portion of 5 is also, various branches of 5 are also in this location. Here we see the pituitary. at the midline. These are the various structures that travel through the cavernous sinus. If we look at the blood supply from the dura, it's coming off of the meningeal artery. And you can see, if you look at the skull, you may be able to see ridges that indicate where the blood vessels were. And you see the middle meningeal artery is a very prominent one. The innervation of the dura is largely from cranial nerve 5, that is a trigeminal nerve, for the anterior middle cranial fossa, and cranial nerve 10, the vagus, for the posterior cranial fossa. Headache is sometimes associated with increased intracranial pressure from stretching of the dura. Not because the brain itself has pain fibers, but because the stretching of fibers within the connective tissue, the dura itself, will produce considerable pain. Damage to these brain vessels may result in a variety of different kinds of hemorrhages. If there is damage to a vessel in the location below the dura, we might see a hemorrhage in the epidural space above the arachnoid. The subarachnoid space contains CSF. The cerebral arteries and veins are located in this region. An epidural hemorrhage is often due to a skull fracture or tearing of one of the meningeal arteries. And bleeding occurs between 2 layers of the dura or between the periosteal layer of the dura and the skull. It's a life-threatening condition, and hemorrhage associated with swelling of the brain compresses brain tissue and the vasculature in the brain. There's also the possibility of a subdural hemorrhage. Subdural hemorrhage might involve some of the bridging veins which traverse the subarachnoid space to enter the superior sagittal sinus. In the elderly, it's very common that these bridging veins, due to shrinkage of brain tissue, the veins are stretched and they may tear, producing a subdural bleed or a hematoma. We see here the falx cerebri and the subdural hemorrhage. Subarachnoid hemorrhages are those that appear between the arachnoid and the brain, and it's most commonly in the subarachnoid space due to a ruptured aneurysm. Typically, they result either from head trauma or a rupture of an arterial vessel with an aneurysm that is a dilated arterial wall. They often are accompanied by a terrible, intense headache, referred to as the worst headache of the life, and they're due to stretching of the meninges. There may also be a hemorrhage within the parenchyma. That is, we see here an acute hemorrhage within the parenchyma, often associated with edema nearby in the blue, and that occupies space within the calvarium, will push the brain tissue over to the opposite side, and we see here evidence of pressure from the hemorrhage on this side, producing a very strong movement of brain tissue to the opposite side. Compressing that brain tissue results in dysfunction of that tissue. There's often an increased intracranial pressure. We see the loss of the ventricle on this side, and it's referred to as a herniation syndrome, pushing tissue away from its normal location. The aneurysms that we identified are dilated arterial walls, and we see one of those here. You see the anterior cerebral arteries on either side and the anterior communicating artery, and we see that there's a bulging of the vessel involving the anterior communicating artery. That can occupy space, causing some symptoms, or it can bleed and causing a subarachnoid hemorrhage. And if it's detected early, before the bleed, it may be coiled, and that will block blood coming into this region and prevent the bleeding. The most common aneurysms are berry or saccular aneurysms that occur at various bifurcations in the circular Willis. Increased blood pressure and cardiovascular disease can predispose people to development of these aneurysms. We can see the common location of anterior communicating artery aneurysms that might affect the vision in this location, that might affect the visual field due to damage to the optic chiasm with compression in this region. And posterior communicating aneurysms in this region are often associated with cranial nerve 3 palsy due to damage to cranial nerve 3. Another type of vascular abnormality is an arteriovenous malformation, an AVM. This is usually a congenital condition where there is an anastomosis between arteries and veins, so that blood is flowing more rapidly than it normally does. These tend to swell up. They may go undetected for a long period of time, and they can gradually grow, but they may also have a tendency to bleed. If they produce a mild symptom and they're detected by arteriography, they may be surgically treated. We see here a nest of vessels, which is commonly seen on an arteriogram with an arteriovenous malformation. We want to turn now to the ventricular system, and that is, you see a number of different structures in this representation of the ventricular system, and we're looking at it from above. So you see the lateral ventricles here, and you see the inferior horn, that would be in the temporal lobe, the posterior horn, that would be in the occipital lobe, and you see this most anterior lobe horn of the lateral ventricle, which is in the frontal lobe, and then the lateral ventricles connect to the third ventricle. You see here, third ventricle is in the midline right near the thalamus, and then connecting from the third ventricle to the fourth ventricle is the cerebral aqueduct, a narrow pathway that enables CSF to come from the third to the fourth ventricle. That's an area that is of great interest to us in the brainstem, in the midbrain, because it is susceptible to being occluded. And if it's occluded, these areas start to swell up, and that is, you get hydrocephalus. And the fourth ventricle is in the brainstem between the cerebellum and the rest of the brainstem, and we see that the outlet of cerebral spinal fluid is going to go off to the sides or to a midline exit. We see now a lateral view of the lateral ventricles, of the third ventricle, of the cerebral aqueduct, of the fourth ventricle, and the foramen of Luschka, lateral recess to allow exit for cerebral spinal fluid, and the foramen of Magendie to allow exit of the cerebral spinal fluid, and an outlet to the central canal for the spinal cord. Notice that between the lateral ventricles and the third ventricle, we have the intraventricular foramen of Monroe that allows CSF to go from the lateral ventricle to the third ventricle. We see here now, removing some of those ventricles, we can see the region and tissue around it. So the third ventricle would be right here, and this is the thalamus that we see. And just above that, with cut array, we see some of the tissue that produces some of the cerebral spinal fluid, and that is the choroid plexus in here that produces some of the CSF. And third ventricle would be in this region. We then see the cerebral aqueduct, this narrow canal going down to the fourth ventricle between the cerebellum and the brainstem, between the pons and the medulla here. And again, there's some choroid plexus in this area that's producing cerebral spinal fluid. There's also choroid plexus on the lateral ventricle, which we don't see here at the midline. Notice the large corpus callosum, white matter that goes between the two hemispheres. The flow of CSF is indicated here. It starts out in the lateral ventricles, travels through the foramen of Monroe to the third ventricle. Some additional CSF is produced in the third ventricle. It then travels through the cerebral aqueduct into the fourth ventricle. from the fourth ventricle. It travels through these various exits, the median aperture and the lateral apertures, the Luschka, and this is Magendie, into the subarachnoid space, and it's dumped into the subarachnoid space, and the CSF provides buoyant support of the entire brain and surrounds the entire brain, both at the dorsal surface and the ventral surface. We see some of that CSF here, and it turns out that CSF, which is produced in the ventricles, goes through that big pathway we just described, comes out through the subarachnoid space, and exits from the subarachnoid space, because it's being produced all of the time, into the superior sagittal sinus. It dumps it into the superior sagittal sinus, which connects with the dural venous sinuses. We see where the CSF is produced here in the lateral ventricle, in the walls of the lateral ventricle. You'll see choroid plexus. You see some over here as well. We see some of the production of CSF in the choroid plexus, and that is, you see very small blood vessels coming in around the choroid plexus. And these choroid capillaries then allow some movement, filtration of blood through fenestration, small holes in the choroid capillaries, as well as some active transport across the choroid epithelium. And that then flows into the cerebrospinal flace in the subarachnoid space and produces the CSF in that choroid plexus. CSF is a clear fluid. It contains a variety of salts, glucose, a little bit of protein, and not too many mononuclear cells. It's somewhat similar to the composition of blood plasma. It is produced continuously all the time, about 500 cc's a day, and it's surprisingly constant. It's not one that's regulated very much. Even if there's blockage, it becomes a problem because it continues to be produced. CSF, as we said, provides a cushion for the brain with a buoyancy effect. It influences the extracellular environment. It helps to clear away waste produced by neurons that are distributed to the venous system. And it provides some distribution of some neuroactive hormones through the entire CNS. The barrier between blood vessels and the brain is rather substantial, even more so than in most other tissues of the body. And that's because there are tight junctions, occludens, are the substrate of that barrier. They're tight junctions around these vessels. And as a result, blood does, and many materials do not flow through this blood vessel as they would in other parts of the brain, other parts of the body. And it protects the brain from a variety of foreign substances. Some substances are readily transported, but hydrophilic molecules tend to be excluded. Astrocytes also surround those almost all blood vessels in the brain, and they provide an additional form of protection of the brain from substances in the vessels. The blood-brain barrier restricts access both of certain drugs that cannot get into the brain, and it partially isolates the brain from the immune system. It used to be thought to be absolutely separated from the immune system, but there is some access, but it is significantly reduced compared to a variety of other sites in the body. There are a few places where the blood-brain barrier is less prominent, and capillaries are more fenestrated so that some materials can get through. And this is particularly in the area of the posterior pituitary, as we see over here, and various factors that are produced by the hypothalamus are able to get into the bloodstream. We also see the pineal gland that is just in this region, just above the midbrain, also has modified blood-brain barrier so that there's movement of melatonin into the brain more readily. And then in the area postrema, low down near the end of the fourth ventricle. We see the area postrema, and this area allows material from the blood to get into brain, and it's an area that then monitors for various toxins, so that drugs and alcohol can influence that area more than some other areas, and may produce vomiting as a way of getting rid of something that has been taken in. Now, if CSF is produced all the time, there are big issues if you block some of the egress of CSF. So here we see a mass sitting in the fourth ventricle, and as a result, the CSF produced in the lateral ventricles and the third ventricle continues to be produced. It will push brain tissue up against the wall, and in fact, it will push the brainstem down towards the spinal cord. But this, you'll see the ventricles will start to swell, and you'll start to see damage to brain tissue in this surrounding area. And you may see dramatic changes in function, including unconsciousness, as you start to produce increased pressure on deep structures in the brainstem, which are essential for breathing and as well as for alertness. When that happens, you can drain that off artificially by putting in a VP shunt, a ventricular peritoneal shunt. And that is where you put a probe that goes right into the lateral ventricle and draw it off through a tube into the peritoneal space, and simply let the pressure, as it builds up, push the fluid out, and you will find that these ventricles will start to collapse, and it'll decrease the pressure, and you can restore function rather strikingly. You make this extra long so that if a person is growing, if it happens to be a child, it can grow, it can extend with the person. This is a non-communicating hydrocephalus, or an obstructive hydrocephalus, because there is an obstruction within the ventricular system. CSF in the ventricles is in communication normally with the cerebrospinal subarachnoid space. Various infections that produce meningitis, some arachnoid scarring, and even intracranial bleeds can block the egress from the arachnoid into the superior sagittal sinus. And if that happens, then you'll get a communicating hydrocephalus. So that even though the ventricles are in communication with each other, the third and the fourth and the lateral ventricle, they can't get all of that CSF out of the brain into the superior sagittal sinus. And that can cause impairment as well, but you don't have an obstruction within the ventricular system. And that also can end up producing pressure on deep brain structures as well on the cerebrum. And in pushing on different parts of different structures, it may move some structures against hard barriers, which we refer to as brain herniation, and the tissue that is pressed against those hard barriers will start to lose function, and you'll see symptoms associated with different structures that are pushed against a hard barrier, whether it is the tentorium cerebelli or the foramen magnum. There is another condition that we see in some elderly, and that is where the pressure is relatively normal, but it may oscillate somewhat in an undetected way. And in that setting, you may see some indications of what we call normal pressure hydrocephalus, and you get a number of symptoms associated with that, including urinary incontinence, gait ataxia, and some cognitive dysfunction. And it may benefit from shunting as well by drawing off some of the cerebral spinal fluid. Another type of hydrocephalus is hydrocephalus ex vacuo. Because CSF is produced all the time, if there is damage to brain tissue, either due to Alzheimer's disease or atrophy, as you might see following long-term following a stroke, or even surgical removal of a part of the brain for some reason, then CSF will fill up that space. And if you look at an image of the brain, you might see a large amount of CSF in a particular region. And that was simply hydrocephalus ex vacuo. It does not by itself produce new symptoms, and the intracranial pressure is not increased. If there are any questions about this material, don't hesitate to contact me.